Hello, this is the second PowerPoint on alterations in cardiovascular function, and it's actually the third video in the cardiac lecture. I hope that you enjoyed the first one and the links to exterior videos. I'm looking forward to your thoughts on that. We're now going to talk about occlusive vascular problems and review it. We did talk about arteriosclerosis, atherosclerosis, myocardial infarction, and carotid stenosis. We talked about the top three in the first two videos, and so now we're going to talk about carotid stenosis. If you'd like to stop this video and check out the link to a video on YouTube, it really does give a great presentation on carotid stenosis. But basically, whenever you see stenose, it's always a narrowing. That's what that means. And so this is a narrowing of the carotid arteries, and the narrowing can cause a buildup of plaque, or the plaque can cause the stenosis. It's kind of like which came first, but basically plaque builds up, and the risk is that a clot can develop in that clot, as you can see in this drawing right here. Where these come together, there's always the risk that buildup can happen, a clot can form, and you know where the carotid artery is. This leads right to the brain. So potential for stroke is very high. Risk factors for carotid stenosis are heart disease, diabetes, obesity, all of those cardiovascular issues that we've discussed many, many times. The problem with carotid stenosis is that it doesn't usually have any signs or symptoms until it's really bad or a clot forms. People who have significant cardiac issues, heart disease, diabetes, obesity, they are checked regularly, and you can sometimes hear bruits when that clot formation is happening, but again, that is more advanced. So we want to make sure that we're checking, or that we're encouraging our patients, to have their carotid arteries looked at on their regular checkups, part of the educational process. Obviously, it's diagnosed with ultrasound, CT, or MRI. And treatment is a carotid endarterectomy, and that's where they basically go in and it's a catheter. It's just like a cardiac cath, except they go in here and they widen this place so that the blood flow is good. We like blood flow to the brain, and also this plaque is pushed out of the way, so there's less risk of clots. People who have carotid stenosis, who've had a carotid endarterectomy, there's a stent placed just like with a cardiac cath. So they will be on antiplatelet aspirin, meds like aspirin and clopidogrel. Obviously, when you have a carotid endarterectomy, we're going in there and we're kind of roto-rooting this and stretching it out, and the risk for stroke is high. And if someone strokes, then it's an embolic stroke, and it's a CVA, right? A cerebral vascular accident that causes what they call cerebral ischemia. Cerebral ischemia is just death to the brain tissue, just like cardiac ischemia is death to the cardiac tissue. It can also happen in the brain. Another risk for with carotid stenosis and endarterectomy is the risk of nerve damage, facial nerve damage. So we need to make sure, again, that the patient is well educated regarding the benefits and the risks of the procedure. Consent, of course, is acquired. That's acquired by the doctor. But nonetheless, the client is going to have questions that you are certainly able to answer. Again, there's other things we can do. Cardiac angioplasty, endarterectomy is like roto-rooting, angioplasty, stenting. They can do a carotid artery bypass. And if we go back to this one, what a bypass looks like is they will take a piece of a vessel from usually the leg, sometimes the upper arm, but usually the leg, and they attach it here. And they go around, let's see if I can make this happen. They go around this clot with a vessel, and put it here. So basically it's like making a road. And then this vessel can close off and it won't hurt anything because this blood flow is going up here. So those are our main treatments for carotid stenosis. And again, think about as you're studying what is the pre-procedure treatment. So pre-procedure, we're going to have them NPO, just like any kind of surgery. If they're going to stent, they're going to give them some clopidogrel ahead of time, because once they stent it, they don't want any vegetation hooking to that vessel and to the new stent. If they're having carotid artery bypass, an endarterectomy or angioplasty is conscious sedation. They're not fully put out. It's not surgical. They go through a vessel similar to a cardiac cath. But a carotid artery bypass is an actual surgical procedure where a vessel is replaced, and they'll have scarring. And post-operatively, of course, we're going to watch their breathing. We want to make sure that we watch for any signs of nerve damage, and that we watch for any kind of passing of a clot, so stroke symptoms for these patients. Next thing that can happen to the heart is endocarditis, myocarditis, and cardiomyopathy. And these are like all sort of the same but different. So there is a video, again, that I found that covers all three of them and certainly should help you make sense of them. And there's also on the following slides some tips to be able to discern which one is which. Endocarditis is, when you see itis, of course, it's inflammation or infection. And this happens usually if there's a compromised immune system. Sometimes if someone has an artificial valve, heart disease, or any kind of weakened heart, if they're an IV drug user, or if they have significant gingival gum disease. So, really horrible teeth, really horrible problems. When you see artificial heart valve, heart disease, or valvular disease, know that these patients are going to be on prophylactic antibiotics whenever they have any kind of procedure. They'll also be probably on anticoagulants, that kind of thing, but that's not considered prophylactic. Prophylactic is when you want to avoid a problem. So if they have to have dental work done, and they have a valve, or they have heart disease where their heart is weaker, these people will be on prophylactic antibiotics if they're going to have dental work, if they get hit in the mouth, like young people who have valve issues. They have standing orders, and they carry with them, like at school, there's a little kit of antibiotics for them. So if they get hit in the mouth, they're given like 2,000 milligrams of penicillin, and then so much every 4 hours for the next 24 to 48 hours. And the same happens with any kind of dental work. Now, that doesn't mean that the patient is going to get an infection or get endocarditis just because they get hit in the mouth or have work done. What we're trying to do is stop that from even happening. But let's say they didn't know they had a valve problem. They didn't know they had a weakened heart, and they weren't on any kind of prophylactic treatment. Signs and symptoms of endocarditis are fever, chills, achy muscle. This is a sick person, and they feel it's very flu-like. Then they may develop a murmur. They might develop splinter hemorrhages, so it looks like little red lines coming up in their nails, and then petechiae, which is the little purple under the skin marks. Some of them get rather large. That doesn't all happen with endocarditis, but it's quite often symptoms of it. Myocarditis is an inflammation of the myocardium. So the myocardium is the actual muscle of the heart. Endocarditis is the surrounding. Endo means in, so it's inside the heart. Endocarditis is going to affect like valves are going to get vegetation on them, that kind of thing. Myocarditis is this actual muscle itself becomes infected or inflamed. So think endo means inside the heart. Myo means cardiac muscle. And the third one is cardiomyopathy, which is muscle stretching, and we'll talk about that one in just a few minutes. Myocarditis, again, you're going to see kind of the same signs and symptoms, maybe a little bit different. Usually happens after a viral infection. They also might have enlarged lymph nodes. They don't usually develop a murmur because, again, the problem is the actual muscle. It's not inside the heart or in the valves. Treatment is antibiotics, bed rest, treatment for heart failure if they go into heart failure. So that'd be beta blockers, just like anyone in heart failure. We really want to watch the medical history when we're dealing with these kind of disease processes, because if they don't have documented valve problems and artificial valve, we got to figure out what is making their heart so weak and threatened. So knowing their history, giving them education, figuring out what brought this on is very important so that it doesn't happen again. With endocarditis, we're looking for a murmur as far as sound goes. And for myocarditis, we're looking for crackles. Again, the muscles actually inflame. So think about what the big muscles of the heart do. They push the blood out into the body. If that's not happening, you can have crackles, dyspnea, all of those signs of heart failure similar to what you would have in someone, an older person with CHF. Here is a slide that talks about the 3 different kinds of cardiomyopathy. And if you watch the video, you will understand this maybe even a little bit better. But one of the acronyms they use in the video is Dr. H. And I like that one because it really distinguishes what the different kinds are. So when you think of D, which is dilated, think of the heart muscle as becoming very dilated and thin. And when you think of R, think restrictive. So that means that muscle is actually hardened and it's just not going to be supple, and it's not going to expand and contract like the heart muscle should. It's very rigid. So think R for rigid or rock hard. It just doesn't budge. And then H is hypertrophic. And hypertrophic means it's huge. The heart just gets big. And when that happens with cardiomyopathy, it's like taking a balloon and you blow it up and let the air out, blow it up and let the air out. And every time you do that, that balloon gets a little bit bigger. And then as that balloon ages, like stick it in a drawer for a while, pull it back out, it's going to become far less supple, far less able to manage the coming and going of the air in a balloon as the same as the blood in the heart. Here is another slide that just talks about what causes different kinds of cardiomyopathy. Dilated is genetics, so they can just be born with it with no other issue. Infectious myocarditis, hypertension, valve disorders, alcohol, cocaine use, all of those abusive things can cause it. Hypertrophic is heredity. It's just a dominant trait. And finally, hypertrophic restrictive distended is usually from some sort of an illness or injury. So this ends this video. So this is cardiac video number 3. We'll end with this and we'll pick up on slide 14, cardiomyopathy, in the next video.